disorders. And Reed, I'm so glad that you're on today because, you know, to have a psychiatrist that I can reach out to, you know, for help with particularly some really challenging patients with multiple psychiatric comorbidities is really, I think, been essential, you know, to my learning and success in caring for these patients, you know, in a primary care setting. So, Reed, feel free to stay off mute, and I'll try and pause periodically so you can add your expertise to this as well. Health meds, and then finish up with vitamins and dietary supplements. So, you know, but I think one of the most formidable barriers, you know, in terms of medications, and for that matter, you know, care is really around access to care, and particularly access to psychiatric care, which, you know, can be an interminable wait. And certainly, you know, I know everybody is aware of this issue, and, you know, we're trying to, you know, recruit more physicians, whether they're psychiatrists, triple boards, or even family physicians who are willing to provide this type of care and in the most broad sense, both, you know, managing their psychotropic meds, but also managing all the downstream health consequences of disordered eating and eating disorders. But access to care definitely remains a barrier, and sadly, it costs a whole lot more than 5 cents. So in terms of eating disorders and medication use, to my knowledge, there are only 2 medications that actually have FDA approval for use in eating disorders. Fluoxetine's had an indication for bulimia nervosa for probably close to 20 years, if not more. And lisdexamfetamine, which we, you know, more commonly know as Vyvanse, has an indication for binge eating disorder. There are, in fact, no FDA-approved medications for the treatment of anorexia nervosa yet, at least in one study of over 500 patients who have been admitted to an eating disorder residential treatment program. You know, nearly 86% were on at least one psychotropic medication, the vast majority of which were antidepressants. And you can see that, at least in this program, slightly more adults compared to adolescents were taking some type of psychotropic medication upon admission. So let me just pause there for a second, and Reed and maybe others at Center for Change would like to hear, you know, what your experience is, you know, when you have patients that are coming into the Center for Change facility.
What we'd say is you're going to have Reed speak, because we're working primarily in the outpatient side here and don't have access to that data.
Okay. All right, well, maybe we'll hear from Reed a little later. Sadie, can you go to the next slide? So let's just talk about psychotropic medications for comorbid mental health conditions. And, you know, this is an incredibly truncated list, and I realize that it could be much longer, and we could spend, you know, probably half a day talking about medications and their use in this patient population. So I've just kind of pulled out a few highlights, and obviously not in great deal of depth. But this is the type of information I often share with my colleagues in primary care, that, you know, in choosing a medication to address mood disturbance, you know, since we see such high rates of comorbidity of depression and particularly anxiety disorders in this population, that fluoxetine is generally the first choice, especially in adolescents. You know, it's pretty safe, and it won't work for everyone. But if we start with the construct of first do no harm, it's probably least likely to really activate somebody who may not have well-developed coping skills, maybe early on in their treatment doesn't have a great therapeutic relationship yet with a therapist, and may be particularly at risk for excessive activation from some other medications. And of course, it's generic. It's been generic for a really long time, so it's oftentimes not as cost prohibitive as some other medications. Sertraline is certainly used quite commonly to address mood disturbance. I like to say that it's fairly middle of the road, not too activating, not too sedating. It has a wide therapeutic range, which can be, particularly helpful. It works a little bit faster than fluoxetine. One of the things I think that's worth pointing out is that it can definitely stimulate appetite. And I'm quite cautious using it in patients, who are at the higher end of the BMI scale, who are maybe struggling with the combination of both restriction and binging. In my experience, it's been a little problematic in people in terms of helping their mood disturbance, but leading to some weight gain, which then adds fuel to the fire with body image disturbance. It doesn't mean I don't use it, but I think you have to be aware that it can cause some appetite stimulation. I think the SNRI group, so Effexor, Pristiq, and Cymbalta, there's not a whole lot in the literature about using them in this population. Certainly, they're at least second-line agents in terms of comorbid, or in terms of mood disturbance. And I have found, Cymbalta and it's kind of its impact on pain to be beneficial in people who have, comorbid chronic pain syndromes. And let me just pause there in case anyone else on the platform wants to address either SSRIs or SNRIs in this patient population. Okay, well, let me move on. Wellbutrin. So, my general rule of thumb is that this is contraindicated in patients with purging. And that's having said that, I have some patients who, do engage in self-induced vomiting or laxative abuse, who are taking Wellbutrin or have come to me taking Wellbutrin. I generally try and transition them off Wellbutrin onto another medication, but all you can do is kind of lead a horse to water, so to speak. And it doesn't. I have very little say over people who are taking it from another prescriber. But this is generally contraindicated in patients with purging because it lowers seizure threshold, and patients can have seizures. And I'm going to address that a little bit more later on. Remeron, probably third tier in terms of a medication to address mood disturbance. It's worth noting that it can stimulate appetite. So if you're looking for adjuvant, therapy, somebody who's, for example, already on an SSRI, and maybe not having the desired response, and is at the lower end of the BMI scale, you might consider using Remeron, in terms of both controlling or supporting mood and stimulating appetite. But be careful with that, along with, as we'll get to with some of the atypical neuroleptics as well, or just neuroleptic medication in general. The internet is rife with information on medications that can stimulate appetite. And the minute you prescribe something like cyproheptadine or Zyprexa or Remeron, the first thing they do, probably in the exam room while you're printing up your prescription, is they're on Google, and they're looking it up, or they're on some pro-ANA website and looking it up. And the minute they see that it stimulates appetite, A, they don't fill it, or B, they lie to you and tell you they're taking it when in fact they're not. Or C, and even worse yet, you kind of lost your credibility with that patient. Unless you come clean and say, yes, I'm prescribing this because it can stimulate appetite and help you gain weight, which may be your goal, but not theirs. So you just have to be really careful with medications that are specifically designed in this instance to stimulate appetite because of all those reasons. And like I said, this is applied pharmacotherapy because this has been my experience in caring for patients with these diseases over the last 20 years. Again, I'll pause there. Anybody want to add to that? I'm sure our Center for Change and our state hospital colleagues have experienced similar.
This is Chris Wallace. I can't add to that, but I do have a question, Liz.
Sure.
Is the metabolizing of the medications ever significantly affected precisely because of the malnutrition or the eating disorder itself, the effects of that?
Yeah, that's a great question, Chris. When some of the early papers on fluoxetine, for example, recommended doses as high as 60 milligrams a day of fluoxetine because, you can't make something out of nothing. And, these are selective serotonin reuptake inhibitors. So, right, they're blocking the reuptake of serotonin at those synapses. But if there's no serotonin at the synapse, then you can block the hell out of it, but, there's just not going to be any around. So what we find is that when somebody is, in dietary restriction, they're just not making adequate levels of serotonin. They're not making, adequate levels of melatonin. That's why we see anorexia, insomnia. So they are really struggling, to kind of meet those central nervous system metabolic demands. So the medications are just less effective. I'm not sure if it affects the metabolism of the meds per se, but certainly, in terms of the desired effect of the meds, it's definitely affected.
Thank you for that.
You're welcome. Okay, so in terms of atypical neuroleptics, there's a lot I could write, but I just thought that, maybe a really important take home here is that they are known, as are other psychotropic meds, but the atypical neuroleptics in particular are known to cause prolongation of the QT interval. Particularly some of we're probably into second generation atypical neuroleptics like Geodon. And, there's a black box warning for using that medication in older adults. And so the combination of electrolyte disturbances along with medications that are known to prolong the QT interval can be risky. And so certainly we need to be checking EKGs in patients, who, are significant purgers and are taking atypical neuroleptics to ensure that we're not putting them at risk for a fatal arrhythmia. Not that we practice N of 1 medicine, but since the first of the year, I've seen 2 patients who have had a cardiac arrest, as a result of self-induced vomiting. One of whom has an implantable defibrillator because she never came clean to anyone during her hospitalization that her potassium of 2.2 was a result of self-induced vomiting. So we just have to be really careful, with our medications and always remember, first do no harm. And then there are another class of medications that, we oftentimes see prescribed to this patient population are mood stabilizers, which are oftentimes anti-epileptic medication. And certainly they may be very helpful in our patients with bipolar disorder. And I don't need to go into detail in regard to that. I think it's worth pointing out that topiramate, which is also an anti-epileptic medication, was actually found to be useful in patients with binge eating. I'm not sure we fully understand the mechanism of why topiramate helps patients with reduce their binge eating or the urge to binge, but in some it can be incredibly helpful. Unfortunately, with topiramate, there are some dose-related side effects, and as you push the dose higher and higher, it does cause some cognitive slowing. And so, kind of the word on the street with topiramate, which is known as Topamax, is the Dopamax. that makes people feel dopey. And so when you get into the 150 to 200 milligram per day range, they feel cognitive slowing. And then lastly, I included sleep medication. And again, there's a lot that could be, written in this category. I just thought it was appropriate to mention Ambien since it's so commonly prescribed. Not that efficacious actually, but very commonly prescribed. It's known to cause night eating. And I have had more than one patient. In fact, just last week, somebody told me that she had an experience with Ambien. I did not prescribe it, but we were talking about sleep medication for her. And that sure enough, she came downstairs one morning and her kitchen counter was covered with bread and peanut butter and jelly. And she had no memory whatsoever of getting up in the middle of the night and going downstairs and making herself who knows how many peanut butter and jelly sandwiches and consuming them. So it is a known side effect, I guess, for lack of a better term, or consequence of Ambien. So be cautious prescribing that because it can result in night eating. Not to mention it can cause night driving too. And I did have a patient who woke up in a parking lot once. Okay, let's go to the next slide. All right, so I kind of grouped these together, and as I mentioned, Dan Jackson, he's a pediatric gastroenterologist. He'll be joining us in May to talk about gastrointestinal complications and management in eating disorder patients. But just at a very high level, for patients with gastroesophageal reflux disease, certainly very common in our patients with bulimia who have scarring at their gastroesophageal junction. So it's a little bit like their stomach is a water balloon open at both ends. And so when they have contraction of their stomach, they're having food and gastric acid that refluxes back up into their esophagus. The way we generally treat that, aside from getting them to stop purging, is to prescribe a proton pump inhibitor like omeprazole, commonly known as Prilosec. There are many others. Most of them are now over the counter, which is a good thing, bad thing, but that's certainly generally the medication to be prescribed. There are other things that you can do, like elevate the head of the bed and talk to them about foods that can contribute to reflux, like caffeine and chocolate, alcohol. There are lots of lifestyle things you can do as well, but from a medication perspective, it's generally proton pump inhibitors, and most of them are now over the counter. There is a medication called Reglan, which probably could have also fallen into that kind of pro-motility bucket as well, and it promotes peristalsis of the stomach and intestine, and it's very effective. However, it's what we would refer to as a dirty drug, meaning it has lots of different medication interactions. It can cause sedation. It can cause electrical disturbance in the heart. It is a challenging medicine to prescribe, and so I think most of us try to avoid it. And in terms of constipation, very common, and nothing in, nothing out, is certainly part of that. And the gut is a muscle. And when that muscle is not stimulated regularly, it gets lazy, just like other muscles in our body. And so for people with restriction or people who are binging and purging everything that they put in, it really sends a lot of mixed messages to the gut. And so the gut, doesn't have its normal kind of rhythm in terms of, it starts with mastication. So you're chewing, and those kind of digestive enzymes in the mouth, begin that digestive process. And then the chewing prepares the esophagus, and the esophagus dilates in response to chewing and readies to receive the food. And then that stimulates the peristalsis, or the contractions in the esophagus, which then push the food, it opens up the gastroesophageal junction into the stomach, where, again, enzymes are released in the stomach. Food is, again, more digested. It goes into the duodenum, or bile acids, and pancreatic acids are used to do digestion, and then into the small intestine where nutrients are absorbed, and then into the large intestine where fluid is by and large absorbed, which ultimately forms stool, which is then passed. So, that is a very rhythmic process. And so you can imagine when people either are restricting all the time or they're eating and then throwing up that food, that it really disrupts that rhythm. So, then we have to go in there and, it's kind of like grabbing an Italian sausage with your hands, and pushing it out of the casing. So we're trying now to throw all these medications at the gut to try and get it contract when, and it's gotten kind of lazy and it's missed it doesn't have that rhythmic process intact. And I kind of started with the least quote unquote invasive to most invasive, and I think for dollars, this is probably appropriate too. Magnesium citrate can be purchased over the counter. I tell people to get it at GNC, where it's actually a mixture, I think, of magnesium aspartate, magnesium citrate, and some other. I can't remember what the third one is, but I think it's around 400 milligrams daily, and you can get it at GNC. The reason I send people to GNC is because they all their products undergo testing. So when you buy the magnesium citrate, you're actually getting magnesium citrate. Erythromycin is another one. You can prescribe this upwards of 3 times a day, 250 milligrams about 30 minutes before meals, and that's also a pro-motility agent. Erythromycin, however, like Reglan, is a quote-unquote dirty drug. It's metabolized through the liver and with cytochrome P450, and can upregulate and downregulate the metabolism of other medications. And so it can be a little bit tricky to prescribe. So you just have to be cautious about drug-to-drug interactions. And then the last two, Amitiza and Linzess, are branded, expensive. Certainly have been detailed to our GI colleagues a great deal. Their primary indication is for chronic constipation or constipation predominant irritable bowel syndrome, but certainly can be considered for use in this population as well. Any questions about GI medications? And like I said, you'll hear more from Dan about this in much greater detail in May. Okay. So I just listed 2 urologic medications. I don't really understand why people end up with problems with urination, with eating disorders. I'm guessing, it's the same deal as eating, that, people who are restricting food are oftentimes, not always, but oftentimes restricting fluids as well. So it just kind of messes up, kind of the autonomic function of the bladder. And so people end up with a urinary frequency where the minute they get any fluid in their bladder wants to contract. And they'll tell me that it really disrupts their sleep at night. They may be up multiple times a night to urinate. And their sleep can already be disrupted for other reasons. So Detrol and Ditropan are 2 relatively inexpensive anti-spasmodic medications. Detrol is probably a little bit better tolerated. It has lower side effect profile. Ditropan particularly causes dry mouth, which people don't like. It's a lot less expensive than Detrol, although I think both are generic now. And Ditropan falls into the same category as Reglan and erythromycin on this slide, as being a bit of a dirty drug, and you have to be careful with drug-to-drug interactions. Okay, let's go to the next slide. All right, let's move on and talk about reproductive health. This is another area where I get a lot of questions. I've been very active in the Female Athlete Triad Coalition, which, really addresses that relationship between low energy availability with or without eating disorders, menstrual dysfunction, and low bone mineral density. And we see this in both athletes and non-athletes. I really think that when you're addressing this, you have to say, does the patient have a need for contraception? Does the patient have a need for hormone replacement therapy? And if so, do they have a need for contraception? Versus somebody who needs hormone replacement therapy but does not have a need for contraception. And so, for people who would meet the criteria for hormone replacement therapy and they have a need for contraception, then probably the preference is to use NuvaRing, which provides estrogen and progesterone, but it does so through absorption through the vaginal mucosa. And that avoids first pass metabolism in the liver, which is much better for bone mineral density. So when people are taking oral contraceptives, as either hormone replacement or contraception, they're known to suppress IGF-1, which is a bone trophic factor. And so we really discourage the use of oral contraceptives for somebody who is amenorrheic as a result of an eating disorder, whether they have a need for contraception or not. And for people who do not have a need for contraception, probably the best treatment is to use an estrogen patch followed by oral progesterone. There's a woman at Harvard named Madhu Misra. She's a pediatric endocrinologist who's done a great deal of work in this area and amongst adolescent females who met the criteria for hormone replacement therapy. When they were given estrogen patch with cyclic progesterone withdrawal, they had improvements in bone mineral density. And that improvement was seen in people who improved their nutrition and weight restored, and in those who did not weight restore. So certainly the people who weight restored did much better because they were getting, additional nutrients and calories, because you can't make something out of nothing. But even those who did not weight restore still demonstrated an improvement. Now, the caveat with the patch is that, at least in the athlete population that I see as a sports medicine physician, they don't necessarily like wearing the patch. They're sweaty, they worry about the patch coming off, or they are, wearing sleeveless shirts at practice and they don't want people to see their patch. But if they put it on what would be under their sports bra, it rubs off when they take a tight sports bra off. So, I find that I actually use the NuvaRing quite a bit. The evidence in terms of its use as hormone replacement therapy and bone protective is not as strong as the estrogen patch, but know that you have options, because not everybody wants to put a NuvaRing in either. So I always ask girls if they use tampons or pads before I would prescribe Nuva. If they are using pads and they're not comfortable using tampons, I would not use a NuvaRing, because they get too freaked out putting them in. Like I said, this is applied pharmacotherapy. Okay, let's look at the next slide.
Liz, can I ask a question?
Yeah.
What about IUDs? With like the hormonal IUDs, is the hormone too low to help with bone mineral density?
Yeah, IUDs, so the hormone that helps with bone mineral density is estrogen. And the IUDs, the hormone eluting IUDs only contain progesterone.
Okay.
So they don't help with bone mineral density at all.
Thank you.
Same with Depo. Depo-Provera is just progesterone. So no help with bones with that one either. So when people do need medication to address their bone health, that we have a number of choices. Probably what's used the most are bisphosphonates, and those are the three that we currently have: Fosamax, and Actonel, both of which can be taken daily or weekly, and then Boniva, which can be taken monthly. All of them have been shown to reduce the likelihood of hip fracture, and some have been shown to actually improve bone mineral density, depending on how the study was done. It's best if used in women past reproductive age. However, there are some studies in the literature in women with a condition, a genetic condition called osteogenesis imperfecta, which results in very low bone mineral density and fractures. It does suggest safety for the fetus in terms of their subsequent bone health, but I'm not sure how long those newborns and toddlers and children have been followed. Some of the OI patients have taken bisphosphonates throughout pregnancy and have had, at least to our knowledge, healthy babies. But nonetheless, it's best, to probably, use these medications when somebody has decided that they're no longer planning on having kids. The bisphosphonates are released from bone and can be detected in a fetus. There are other bone medications. Forteo is an injectable parathyroid hormone, or PTH, and that's sometimes used particularly in people who have slow healing or non-healing fractures. I probably should have put reclassed ahead of Forteo in terms of how it's used. I've never used it in a young person with an eating disorder. I do have a handful of older females who have had lifelong eating disorders and have really horrible bone mineral density, who just didn't have sufficient response to oral bisphosphonates. It's a yearly infusion that's done. It is associated with a condition called osteonecrosis of the jaw, whereas the oral bisphosphonates are not. So just a word of caution, in our patients who have been purgers and have really bad dental hygiene, and there would be a contraindication for reclass in that group because it has been associated also with, there's a relationship if you pull out a tooth in somebody's mouth and they're on an IV bisphosphonate, that seems to trigger this osteonecrosis of the jaw. So in somebody with purging disorder or bulimia or purging type anorexia, I would use IV reclass with caution. And then the last one is nasal calcitonin. And this is often used to treat those who have osteoporotic spine fractures, and particularly those with spine fracture pain. I don't think I've used it in anybody other than that. It's very expensive, and so cost is often a barrier to using that medication, but it's primarily used to treat pain in people with osteoporotic spine fractures. Next slide. And then vitamins and dietary supplements. So, I kind of put, why not with a multivite? I'm not a huge fan of vitamins. I'd rather see people get their nutrients from food. But, if they're restricting their intake in terms of total calories or in major food groups, whatever, putting them on a multivitamin, probably not a bad idea. If there's a need for calcium, calcium citrate is preferred over calcium carbonate because it is less likely to be deposited in the endothelium of our vessels. And people who are chronic users of calcium carbonate, whether it was people who were taking Tums, for acid reflux or gastritis, or people who were taking a calcium supplement, if they were taking calcium carbonate, their coronary calcium scores are elevated. So that's the amount of calcium in their kind of cholesterol plaques in the heart. The only problem with calcium citrate is it doesn't have great bioavailability, so you have to split the dose. So if you want to give somebody 1,000 milligrams of calcium a day, they really have to take 500 milligrams twice a day. So just as an FYI, it's available over the counter. It's called Citracal, and there are certainly other formulations as well. Vitamin D. So I think that there's a lot of controversy around vitamin D. Again, be an hour talk in and of itself. You know, you can load people with 50,000 units. You know, almost everybody I see is low or on the low end of normal. And again, this is applied pharmacotherapy. And I think, you know, we want to minimize costs. We want to make it easy for people. So I just have them take 2,000 IUs daily, tell them to get it at Costco. It's cheap. It doesn't cost a lot. They get used to taking it versus prescribing them, you know, high doses of vitamin D. You know, there's no such thing as a vitamin D emergency. So it just, if you keep it simple. See lots of vitamin B12 deficiency as well, and we don't really, I can't even remember the last time I gave anybody a vitamin B12 injection. I think it's been well in excess of 10 years. I've never done it at Intermountain. And if somebody is deficient, we give them 1,000 micrograms daily, and it's over the counter. And likely, and similarly, you know, if somebody has either anemia or they're just iron deficient without anemia, you know, we can give them over-the-counter iron. Most people will tolerate ferrous sulfate. There's a handful that will not, and they may need ferrous gluconate, which is a prescription, but ferrous sulfate is available over the counter at 324 or 325 milligram tablets, and people can take it up to 3 times a day, except nobody does, and it causes constipation. So we often recommend at least twice a day for 6 weeks. There is iron infusions as well. And, you know, for people who end up with, you know, a ferritin of 2 and their hemoglobin is, you know, hovering around 11 or 12, and they just feel crummy all the time because they're just so iron deficient, we'll sometimes do iron infusions in the infusion center, but not very often. Probably do it twice a year. A couple others, melatonin. I already talked about the fact that you can't make something out of nothing, and which is, you know, part of the reason why we have anorexia insomnia is that people aren't making sufficient melatonin. And so an easy thing to remember is if they're having problems falling asleep, give them a sublingual dose, which is more easily absorbed. If they're having problems staying asleep, you know, give them a swallow pill, generally around 5 milligrams. I think you can go up to 10 milligrams, but I have found that patients tell me that at 10 milligrams, they have weird dreams. And I typically send people to GNC because they do product testing, but these are the labels that you can look for, or you can tell people to look for on their melatonin, which would indicate that the company undergoes voluntary product testing. So either USP, NSF, or the CL label would be consistent with that. There, 60 Minutes did a expose on melatonin a few years ago, and they pulled all these products and they took them to a lab, and I mean, very few of them had any melatonin in them at all, and some of them had far less active medication in it or substance than was described on the package. And only those that had subjected to voluntary product testing met, you know, their kind of requirements for being, you know, appropriate. So anyways, buyer beware on melatonin. Another thing to consider for people with constipation, of course, is some type of a fiber. Citracel is, you know, a non-digestible fiber, and used appropriately, it can help. It can also bind some people up. So we always tell people, if you're going to do Citracel, that means that you're committing to drinking lots of fluid. There is an indication for use down to age 6. So it's generally what I use first in the kids who come in with chronic constipation. And then I wanted to mention protein powders. because it's a dietary supplement. And I often ask people to mix it into their smoothies. It doesn't add any volume, but it does add some energy density. Looking at some of the protein powders online, one scoop is about 100 calories, so it's not a lot of additional energy, but more than adding half a cup of blueberries. Tastes good, but no significant increase in energy density. And it's a little covered up there, but 20 grams of protein. So, and next slide, Sadie.
Sorry, I have a question. Do you often see people on sleep medications and taking melatonin at the same time, and are there benefits to combining the two?
Well, they work through different pathways, so I wouldn't have a problem with that.
Okay, so if they're on like a prescription like trazodone for say, to take melatonin on top would be safe?
Yep.
Okay, great, thank you. You
bet. Although trazodone's on my list of medications to avoid or use with caution because it does cause orthostasis. We, pretty much don't use this in older adults because it increases the fall risk. When they go from sitting to standing, they get all wobbly. And so in our really low weight patients, or even people who are purgers, and are having huge, gigantic fluid shifts, trazodone may not be your first choice as a sleeper. And we do not use it in most of our athletes, particularly athletes who have to go upside down like a gymnast. So as a former Division I team physician, if I saw somebody on trazodone and they, for sleep disturbance, and they were a gymnast or a diver, where they had to have, lots of different changes in posture, I would take them off of it because, it increases their risk of injury. So, for the prescribers on the call, on the Zoom platform, I would just be cautious, in using this in patients with low BMIs, in some athletes, and in older adults. And going back to the top, naltrexone goes by the trade name Revia, is often used for patients with different addictions, whether it's opioid or cocaine. I think it has indications for both. It's used in people with alcohol use disorder as well. It can also help to stop the urge to purge. I've had several experiences where, this is a known side effect, it can increase the risk of rhabdomyolysis in somebody who is exercising vigorously. And it's worse if they're hot and dehydrated, which is an independent risk for rhabdomyolysis, which is, breakdown of the muscles. And I've seen it happen twice in patients. One was a woman probably 15 years ago on the U.S. speed skating team who actually ended up with rhabdo up in Canada at a speed skating event and spent a couple of days in the hospital but did not need to dialyze, thank goodness. And then the other one was a gal, probably 12 years ago, who worked at a nursery, garden nursery in the summer and was on naltrexone, and she was throwing sod into a pile all day. She thought it was great exercise, and until she got home and she peed and it was like brown water coming out of her. So she took herself to the hospital and she had bumped her CKs super high. They gave her a whole bunch of IV fluids. I don't think she ended up getting admitted, but it can increase the risk of rhabdomyolysis. So what I say to people, is I don't mind prescribing it, but you have to be really cautious about doing vigorous exercise. And if you're doing vigorous exercise, particularly outdoor exercise in the summer, you should come off of it. It's worth to rediscuss Wellbutrin again. It does lower the seizure threshold. It really, really. And again, I think the prescribers on the call I'm sure have had similar experiences. I've had probably half a dozen patients over my career seize on Wellbutrin, and it really does happen. And so it's worth it to try and get people off of it who are on it, and to not prescribe it, to people who are at risk for electrolyte disturbances. Tricyclic antidepressants and benzodiazepines. Again, the reason I avoid or use with caution in this patient population is because there's just high rates of comorbid substance use disorder, and of course, amongst patients with anorexia in particular, the causes of death, are severe malnutrition, electrolyte disturbances, and suicide. And so a really great way to kill yourself is to, overdose on TCAs and or benzos with some alcohol. So I try very hard to avoid prescribing those, and not always successful in people with really acute anxiety, where we, try and very carefully prescribe benzodiazepines. But I think it's worth noting that we should use these only when necessary. And then I've already talked about birth control pills, which can lower IGF-1, which is a bone tropic factor. So I switch a lot of people off oral contraceptives and put them on a NuvaRing if they have a need for contraception. That was a lot of talking, but hopefully really good information for you. These represent, medications that probably many of you see your patients on regularly, and now you know why, and a little bit about them. So I apologize if it went a little bit long today, but I wanted to get through all of those. So let me pause and just see if there are any questions or comments, from people either in the room or on the Zoom platform.
Okay, let's just go ahead and start with the case then.
All right. But I thought I would present a case where there were some, it ended up having some medication issues because of her underlying health. And so maybe not a whole lot of questions here, but just to kind of as an example of how medication use in this patient population can sometimes be a little challenging. This is a patient who sees me. Her therapist is Gina Hema. And Gina, if you're on the Zoom platform, please identify yourself. And she also sees Janae for nutrition. She is 23 years old, single, does not have any children, lives with roommates, defines her primary support system as her parents and her roommates. Her diagnoses include anorexia nervosa, which she's had for 10 plus years. I've only seen her twice. She's never been in, this is the first time she's ever been in a multidisciplinary care. She has never had inpatient or residential care. She has depression. When I saw her the first time, she was complaining a great deal of sleep disturbance, and she felt like that was contributing to profound fatigue and more kind of chaotic thinking. And so the sleep medication I chose, because she described it as her mind racing and she couldn't fall asleep, and then waking up frequently throughout the night, and having really obsessive thoughts around food, weight, and body image. I chose Seroquel, 25 milligrams at bedtime. And when I saw her back for a follow-up visit, she said it was a quote-unquote lifesaver. So although I didn't mention that when we were talking about medicines for insomnia, it is an atypical neuroleptic, which is typically used to address sleep disruption. She has oligoamenorrhea. Her last normal menstrual period was in 2017. I've only been seeing her since the first of the year in 2019, so essentially no periods for 2 years, although she's had some irregular spotting. And I don't believe she's had a DEXA yet. Some other medical diagnoses she has include vitamin D deficiency by lab, and is now taking a vitamin D replacement. And I found this really interesting. She reported a history of post-traumatic stress disorder, and she was actually involved in the mass shooting in Las Vegas. So we can go ahead and scroll down. In terms of her eating and exercise behaviors, this is where it got even more challenging. She is she's skipping. Let me talk about her dietary restriction first. She skips 2 meals a day, so she actually only has 1 meal a day. She skips 2 snacks. So when we think of 3 meals and 2 to 3 snacks, she's eating, I think, a protein bar and a cup of coffee for breakfast. She said she'd snack on some crackers for lunch, never has any snacks, and she doesn't eat any dinner. Janae, are you remembering who this patient is now?
I have not seen her yet.
Oh, okay. All right, well, I know you're going to fix her. But I estimated she's getting, somewhere between 600 and 1,000 kcals per day. And so eating very, very little. And she admits to some self-induced vomiting and some laxative abuse. She's also doing cardio 5 to 6 days per week for 20 to 60 minutes, and doing, anywhere from 30 to 50 minutes of weight training or Pilates on the days she does cardio. So eating very little, exercising a lot, and engaging in self-induced vomiting and laxative abuse. I thought I would just share with you what she said to me at her last visit. She said she's hungry, but she's scared to eat. She's exhausted. Food, weight, and body image is all she thinks about from the time she wakes up in the morning until she goes to bed. And she admits that it impairs her ability to function. She's finding it hard to concentrate at work. And her energy level she describes as moderate to low. But, and I didn't put this in my notes here, but she told me she was more scared of gaining weight than of dying. So that's just kind of how incredibly distorted the thinking is.
Liz, what was the onset date of her behavior?
2009. And she was a gymnast. And she said she was trying to have the perfect body to do gymnastics. And she started to restrict her calories then. So she's 23 now, so she would have been 13 years old when this started. So she had just kind of gone through puberty, probably, gained 10 or 12 pounds, and then started to restrict.
And then the behaviors that you're presenting, that she's reporting, is there a way of knowing how long they've existed at that level? So was she like from 13 to now doing exactly what's on there? I assume not. So how do you know when this particular presentation? Am I asking that question right? Like.
Yeah, no. I know what you're asking, and I don't know the answer to that. I haven't. Over the course of our visits, really kind of delved into to know how it has kind of waxed and waned over that time. But that's a great question. You can see her vital signs there. They're pretty normal, and her BMI is 22.6. Between the 2 visits I've had with her, her weight hasn't changed at all, despite her dietary restriction and her overexercise, which, you know, just is such a reflection of the fact that she's got such metabolic suppression. I mean, I don't know, you know, it'd be interesting, Sadie, you know, as the exercise physiologist in the group, to see, you know, what happens to their BMR, you know, at this level, you know, with these type of behaviors compared to what would be expected based on our calculations for their age, gender, and size.
Yeah.
We don't do that, but it would be kind of interesting.
I do have the equipment to do that in our clinic, though, if you ever want to track one.
I know. We should talk
Let
more
me
about
know.
that. I probably should have said this before, but her medications are listed there. Fluoxetine, Lamictal, Zofran, and Seroquel. She came to me having been seeing a psychiatric APRN, and I don't think her doses are sufficient to really provide very much benefit. So not being the initial prescriber, I didn't touch her other meds other than give her the Seroquel, but we're going to come back to that in a second. And you can see her labs over there to the right, and they're pretty unremarkable. I thought it was interesting that if we were to look over on the right-hand column, her FSH is almost 6, her LH almost 4, and her estradiol is 33. All of those numbers would, you know, suggest she could menstruate. But in any case, she's just having some irregular spotting right now. But the rest of her labs were all within normal limits, and I don't think she's had a DEXA yet. I think we ordered one, but I don't know if it hasn't been done yet.
Hasn't come through yet.
Okay, that's what I thought. I looked for it, but I didn't see it. So I guess I don't know that I had a whole lot of questions in regarding this case, but I did want to present it because it really kind of, there ended up being kind of some challenges, you know, with her. I mean, given how profoundly she is affected by the eating disorder, I mean, from the time she wakes up until the time she goes to bed, you know, it's clearly impacting her health, her ability to function, and her quality of life. And despite multidisciplinary care, well, almost multidisciplinary care, she still is absolutely fully engaged in her eating disorder. And I really encourage her to consider an assessment at Center for Change and to reach out to her support system, you know, to talk about the possibility of doing some type of inpatient or residential program. Not surprisingly, I strongly encouraged her to exercise less. And in fact, I said none. And we talked about strategies to increase her dietary intake. But that was when she told me that the fear of weight gain was greater than the fear of death. So I thought the likelihood of her increasing her dietary intake was pretty low.
Liz, do
And the
you,
reason, oh, go ahead.
Heidi, so hearing that, but then how motivated is she? Because if that's driving it, right, how motivated is she in an outpatient level of care?
Well, I don't think so. But, you know, it's so interesting, Heidi, right? Because these patients, they come to us, right? I mean,
Right.
They're miserable. She is miserable.
Right.
And yet, you know, that the disease has such a grip on her mind, you know, that she is not able to engage in change. So I really think she is one of those folks who would benefit from a more intensive, immersive treatment, you know, that residents could provide.
Yeah, I was wondering how in your experience of her, how insightful she was about where her motivation levels were versus where the anorexia and eating disorder is working on her. Just was wondering like how much consciousness she had about that as well.
Yeah, none, Heidi.
Yeah.
Really none.
Yeah.
Yeah. You know, having just presented, you know, about medications, you know, she should be on higher doses of meds, but I think I had too many concerns about her heart health given her profound dietary restriction and her excessive exercise in addition to purging behavior. And I just thought, forget it. You need to be on higher doses. I don't think these are effective really at all. I'm glad the Seroquel is helping her sleep, but I was too worried about her heart, and so I did not make any changes in her meds. And then the other thing I learned too was that she's actually only seen her therapist, every 3 to 4 weeks. And, as we talked about optimizing multidisciplinary outpatient care, she really should be seeing her therapist at least weekly. And I'm a little disappointed that she hasn't seen Janae yet. So, she's really not getting. She's on your schedule.
Pretty long wait list. She's really popular.
She is.
Right.
Oh yeah, and I forgot that when I was concerned about her meds, that and I had gone back to review her chart as I was putting this together. That she had told me she was symptomatic with both tachycardia and presyncope. So not surprising given her profound dietary restriction and excessive exercise. So this is an example of somebody who's, absolutely wrapped around the eating disorder, or the eating disorder is wrapped around her, and she's, it's really impacting her mental health and her physical health, and to such an extent that we can't even optimize medication management and, to address any of this. So that's really about all I had to say about this case, but I'm happy to answer any questions. And, if there are thoughts from folks on the Zoom platform about, what's the best next step with her, I'm all ears, and would love to hear from you.
Well, I don't want to create more work for you. I don't know if you've had a conversation with her therapist.
I encouraged her therapist to join us on the Zoom platform.
Okay. Okay. Yeah, I mean, I think that what the value in us meeting, like if you and I are talking, or you and I and a dietitian are talking about levels of care and where I feel comfortable seeing someone at an outpatient level, if they are high risk, right, versus being on the same page as you. So it'd be interesting to find out where her therapist is at with her.
I'm sure frustrated would sum it up.
I got it. But that was in terms of sometimes that's helpful when a doctor reaches out to me and says, hey, I'm seeing this in my office, where are you at with it? Kind of gets it on my radar a little bit better. But I don't want to give you more to do.
Yeah.
Just more to do. What did you say? Oh, Mercedes, right?
If the therapist is not aware of eating disorder treatment, or thinks she is but isn't real, like kind of on that cusp, then this kid could bamboozle her in a heartbeat, and the therapist might not really understand the risk that this kid is at all.
Right, and I think the same is probably true for the psychiatric APRN who's prescribing her medication. You don't ask the right questions. I'm sure she's not taking the time to go through a detailed dietary recall at every visit, or asking about the amount of exercise that she's performing, or asking about, whether or not she's having some of these physical symptoms, which, are part of my kind of standard review of systems. So yeah, right, when we're only as good as the data that we can collect, which is, dependent on both the provider asking the right questions and the patient, providing us with honest answers. So it's a classic, it takes two to tango.
My other thought about it is then having said that, or having listening to you, then you need someone as a therapist you can work with her.
Yeah.
Maybe a different referral option for someone
Right.
that you feel, because I certainly will try to do that, as if I have someone, and like I certainly will have them come and see you if I need a different level of intervention
on an outpatient level with a client.
Yeah.
And I wonder
Yeah,
too, you can require her to get her therapist to sign off this medical presentation. So sort of be like, hey, or get the therapist to at least respond to you and say, look, this is her medical presentation. She needs this kind of level of care. The seeing you once a week is putting her at medical risk with an eating disorder. I think that might like kick the therapist in the bum a little bit.
This is fantastic, you guys. These are all things I know, and I had not done with her, so I appreciate your advice.
Right, and again, like the therapist just might be being bamboozled. She might not know any of this, and I love my new words.
Yeah. Yeah, it does take a village. Any comments from our colleagues on the Zoom platform? Words of wisdom for us.
Hi, this is Steve. I've had my hand raised just testing out the mechanism. Did anybody notice?
I thought,
Yay!
It's on the screen, but that's cool. Oh my God, there you did it.
No, that's good. I just want to echo what both Heidi and Charlene said. I think they have just really good insight on this stuff. When a therapist sees somebody every 4 weeks, that's pretty much maintenance. You know, everything is going pretty well, but they just want to kind of maintain what they're doing. So this doesn't match, obviously, what it is. Is there a reason we know why she's not coming in more frequently?
Yeah, I don't recall if it was a financial issue or another type of, scheduling issue, or if, I can't remember. I think I did ask that question, but I don't remember the real response.
Cool. It's just
She's
an
been
issue
seeing
of
therapist
agendas.
for a while.
Yeah. If she's seen that person for a while and they're at monthly, the therapist either doesn't know what they're just not on the same agenda, right? So
Yeah.
somehow that's got to get cleaned up.
Yeah. So my takeaway then is, for at least on the psychotherapy side of things, for sure to reach out to her therapist, and also kind of to discuss, maybe with the patient. If the therapist doesn't seem super responsive or available, maybe she only works part-time or something, then to maybe suggest that she needs to change to someone else.
Dr. Joy, as a medical assistant, is there anything I can do to help with that workflow as far as getting that information with the therapist and connecting the two of you, or maybe having a formal referral or contract if you start seeing someone out of the rounds group?
Yeah, I think that is some workflow that we could work on, Sadie. I mean, most of the patients we see a member of the eating disorder team, which makes communication easier. But for those folks that are seeing a therapist or a dietitian that's not part of the eating disorder team, we should try and get their contact information and set up, times for me to talk with them.
Okay.
So that would be awesome.
Let me know.
Okay, fantastic. Love that idea.
Hey, Liz, one thing I've been thinking about on all of this too, based on sort of what Heidi had said, right? With anorexia, with all eating disorders, but a lot with anorexia because of the hijacking of the brain and all that jazz. Your motivation question, right? So you're asking, Heidi's asking, is the client motivated? You see sort of the motivation isn't the disorder. The motivation is going to look like, yes, I'm showing up at your office, but I'm participating in all these behaviors and I'm still stuck with the disorder, but I'm showing up in your office and I'm going to my therapist appointments and I'm seeing my dietitian. I'm maybe still struggling with the behaviors because I have an eating disorder, but I'm showing up. That's what I look for when I look for do you have any motivation? A person can be as sick as anything and have motivation. But when you have someone who is really, really sick, clearly being hijacked by the eating disorder due to low nutrition, but they're not showing up, like I'm curious why she even showed up in your office, but like she's not seeing her therapist. She hasn't really like even had her first appointment with her dietitian. It sounds like you've got someone who is one, hijacked and sick, but also is struggling with her motivation for even getting healthy. And that, I think those are really important clients to pay attention to, because they'll fall off the radar. They'll get sick. They'll end up in the emergency room.
It took a long time to get her in too. She rescheduled a few times.
Yeah. So there's like, yes, there's the eating disorder, but then there's also the other, the psychological component of their motivation. And I don't know what you would say about that.
No, the only other question that comes to mind about that then is what support she has. So what?
Yeah, she says.
Yeah.
She says roommates and her parents that all know about the eating disorder, and you know, I almost always ask the question of who's your best friend, you know, and how do you connect with that person, and how do they help you and support you and things like that. And she didn't really name, because I went through my notes to see if I had written down. I usually put down a name if somebody says, oh yeah, this is who my best friend is. And she just said roommates in kind of generally. But yeah, so she at least, I mean, we have some patients, of course, who say they have no support system whatsoever. And, you know, those are the ones too, like Charlene was saying, that I really worry about, the ones that are super socially isolated. They also can kind of fall off the radar. I always have a tiny little sigh of relief when they can at least identify, you know, a support network.
Right. But then with her athletic background too, and her having everything, so she doesn't have a lot of providers in her corner, and so she's got an athletic background. What kind of support are her parents giving, and what kind of support are her friends giving? It could be very much, oh, we support you in being an athlete and staying strong and skinny, so it's supporting the eating disorder, when they really don't know exactly how bad it is. There's just all these variables that this kid isn't letting people know.
Well, you know what else? That's a really good point, Charlene. But I think one of the other things that has probably created that is that her BMI is 22.6. You know, and it's been above 20, you know, for a long time. You know, when I go back in her historical record, if she's been seen in an urgent care for primary care or a GYN visit, you know, it's above 20. So she looks normal, right? She looks like she's at a normal weight. And that is why, you know, we weigh people, we measure them, we document their weight and their BMI. But, you know, if I've got a 25-minute visit with somebody, you know, I bet I spend 2 minutes talking about their weight, you know, and the other 23 minutes about everything else. And yet their personal experience is just the opposite, right? It's all about the weight and the body image. So it's I think that ends up being a challenge for somebody like her, you know, who is quote unquote seen as being normal weight, yet is profoundly disordered in her behaviors and you know, in terms of her ability to function and quality of life, and now really compromised health.
You know, Liz, and I know it's almost time. The only thing I will also just add is, like, she's rescheduled with you, and like she has buy-in with you because you treated her insomnia. Right. And you made her feel so much better just by treating her insomnia. So it's great that she's got buy-in with you. That is just in my thoughts.
Yeah, good point.
Yeah.
We have to fix it all. You know, you fix something, or you help them with something, and then it's taking these chunks, right, that kind of lead them towards health.
And she might be after getting sleep. So I just listening to that piece of that's great.
Yeah, good point.
I have to leave.
All right. Okay, well, you guys, we are at time here. Okie dokie. Well, we'll finish today up. I'm going to go back to my meeting here in Chicago. You guys have a great day, and I'll talk to you later.
Thanks, Liz.
Bye.
Thank you.